United Nations a few years ago when the lights went out and everybody was in the dark, and the Chinese diplomat, Chinese ambassador said, okay, just yelled out loud, everyone raise your hands to the ceiling. And so everybody did that. And the lights came back on. And I looked at the Chinese ambassador and said, what's that mean? He said, old Chinese proverb, many hands make light work. Like Dr. Nesbitt. All right. I'll be here all week. So every now and then we get a new player in the marketplace. And that's often a challenge for people to say, well, who is that company? What are they doing? And why are they here in Georgia? What's their interest and things like that? Well, we have that opportunity. And I think so far, the people who've been influenced in the communities where these hospitals are serving have been very pleased with what's going on. So we have with us Mel Pyne, who is with ER Hospitals. A little bit of a name issue because a lot of us thought, well, these aren't emergency room hospitals, but it's the name of the company. And it's also a company that is relatively new in Georgia. And Mel comes to us from Utah. But he's actually worked out in the Pacific Northwest quite a bit. He's been a CEO for Peace Health in the Pacific Northwest, but that includes some time actually extending all the way up to Alaska, which is the far Pacific Northwest. And so Mel's going to come talk to us about the ER health experience here in Georgia and what that means to the community they serve. So, Mel, thank you. You got your rail mic?
I'll go ahead and use this.
That's great.
Mic, and thank you so much for the opportunity to be here. Good morning, and special thanks to Augusta Health for hosting the symposium today. What I'll do today is share with you the perspective of our management company, ERH Healthcare is what we call ourselves now, in managing hospitals and medical clinics and nursing homes and other healthcare services in 5 rural markets here in Georgia over the last 5 years that we've been involved in Georgia. And I will first describe some of the common challenges that we face in those 5 markets. And I think these common challenges will be familiar to you. And then I'll talk about, we'll describe progress that we've made towards sustainability with the hospitals in these markets. And then we'll also talk about some opportunities and possibilities that we feel that are out there that give us some hope. So let's go ahead and start with where we serve. So the map of Georgia, and we manage a hospital in a critical access hospital starting on the east side there with Cameron County Hospital in Merritt, and then Manual Medical Center in Swainsboro, Georgia. Our newest is Washington County Regional Medical Center in Sandwichville, Germany Medical Center in Fitzgerald, and Irwin County Hospital in Ocilla. And we specialize in helping distressed and underperforming hospitals. And so in this case, we haven't taken the easy path. That's indicated by the state of Georgia did an analysis for the Rural Hospital Tax Credit Program of the 50 rural hospitals that qualified for that program. They had them submit information to determine the most distressed hospitals. And 4 of our hospitals are among the 6 most distressed hospitals. So if we can make progress with these hospitals, we feel like there's hope for virtually any rural hospital in Georgia. So while I have the map up here, let me just make a comment. And one of the fundamental dilemmas for Georgia is that Georgia has all these small counties, I think over 150 small counties with small rural hospitals associated with many of them. with limited population really in each of those counties to support the rural hospital. So that's just a structural, fundamental challenge for Georgia at this point. Let me also just comment that being here and kind of observing Georgia, there's actually 3 Georgias, as you know. There's Metro Atlanta, and there's the secondary metro areas like Augusta, Savannah, Macon, Columbus, Albany. And then there's rural Georgia outside of that. And Metro Atlanta, because of its population, has the loudest voice in Georgia politics. And it goes from there to the other metro areas down to the rural areas that probably have the quietest voice in terms of Georgia politics. But one thing that I don't think is realized fully is that metro Georgia depends on rural Georgia. Agriculture is still one of the leading industries in Georgia. And that, for that reason and for other reasons, metro Georgia needs rural Georgia. But the people that live in the Atlanta area don't think in those terms, and they really don't consider that. So that's one thing that the state really needs to be educated on, is that this rural part of Georgia is an important part of Georgia that metro areas depend on, and that story needs to get out. And then policies need to be determined at the state that recognize that, because that is not the case now. So that's one comment that I would make relative to the, well, we have the state of Georgia here in front of us. In terms of common challenges, I mentioned small counties with small population bases. That's part of the headwind that we're facing as rural hospitals. And you can ask the question, well, how many people do we need to support a rural hospital? That depends on the service mix of the hospital, the payer mix of the community, the size of the hospital, and a variety of other factors. But it's safe to say that to really ensure viability, you need 30 to 50,000 people to support a 50-bed hospital unless you're reaching beyond your county. And so that's part of the challenge that we have, is kind of crossing county lines. I'll speak of that in a minute. That's one of our challenges. The harsh economic environment, we've already seen some information about the high unemployment rates, the high poverty rates, the low education rates, and then we have on top of that Georgia choosing not to expand Medicaid, and just a variety of things that create an environment that makes rural healthcare very difficult in Georgia. And those are real factors that are, it does make healthcare tough, and especially rural healthcare in Georgia tough. And so we are facing that. Each of you need to look at your medical staff, and you need to look at your employee base, and just do an age distribution. Figure out how many of your physicians are in the 30 to 40 age category, how many in the 40 to 50, how many in the 50 to 60, 60 to 70. And it will be a little alarming to you, most likely. It was alarming to us as we look at that data. Most of our physicians are in the 50 to 60 or 60 to 70, and some over 70 age category, and fewer in those younger ages. So it really underscores what Tim Putnam was saying about preparing a pipeline, because as we look to the future, we're going to need that pipeline in terms of being viable and successful in the long run. So do that analysis, and then start to work on that pipeline. We not only have aging people, but we have aging equipment and facilities and technologies, and that's very evident in all the 5 hospitals that we oversee. We've already heard a little bit about out-migration, and I think fundamentally this comes because people like choice. And they like choice in terms of the physicians that they choose, or they like choice in terms of physical therapy or whatever service they're seeking. And there are more choices in larger population centers. And so once they select a physician in that larger population center, reversing that and reversing the out-migration is difficult. But it's something that we need to do as small rural hospitals to be successful. So that's a challenge that all of us face. Hospitals need specialized skills, specialized management, specialized clinical people, technical people, and we've found that as we've had openings, it's difficult to recruit that talent to smaller hospitals. And so it's much different than managing a large medical center. And ERH Healthcare has worked, our principals, we've worked in giant tertiary medical centers, the CEOs of large tertiary centers, small rural hospitals, and everything in between. And we've worked in various markets, Pacific Northwest, the West Coast, Intermountain area, Midwest, Southeast, Southwest. And so we have experience working in other markets, and we know that in some markets, boy, you get 50 or 60 applicants for a certain position, where in these rural areas to get a qualified person, it's more difficult. And then I'll speak to competition in a minute. So what have we done? We have made progress towards sustainability in these small hospitals, and our model is essentially to bring the expertise of these ERH partners and principals and rally around the local teams. And the local teams, we usually have a CEO, a CFO, a chief nursing officer at each site, and we bring our expertise, our 150 years of experience and expertise in various organizations in various places across the country, and rally around those teams and bring as many best practices as we can, whether it's governance best practice that you've heard about this morning, or management best practice, or clinical best practice, and help those teams look at new possibilities. And part of what we bring are benchmarks and performance targets, very similar to what Tammy mentioned in terms of actually setting some targets, looking at data, and starting to hold people accountable. And so it's just a change of culture for most of these small hospitals, is to have some kind of accountability towards some performance targets. We also bring our shared services model, and this is where we have support services and leadership services and in some cases clinical services that we share across multiple hospitals. And so it reduces the cost and improves the service of those particular services. Whether it's IT, most of these hospitals can't afford to have their whole IT department. But if you spread that over 2 or 3 hospitals, you can start to recruit talented IT people. Same with the HR function, or the revenue cycle team, or in the case between Dormany Medical Center and Irwin County Hospital, they're very close, and so we share respiratory leadership and pharmacy leadership and laboratory leadership and a variety of things across these hospitals. And so with each of these hospitals, that saves them at least $500,000 or more, and then it also enhances service as well. So this shared services model, we've got about 75 employees or so that are in that model that are sharing their services across 2 or 3 or 4 or 5 hospitals. And that's made a difference. And what the effect of all of this is that these small hospitals don't feel like they stand alone anymore. And so they feel like they're part of something bigger. They're now part of a network of hospitals, and they're part of something that is stronger than they were as individual hospitals. And so we've created a network of small hospitals without changing ownership or without changing kind of the structure of those local hospitals. Each of these are health authority hospitals, county-based. One is a critical access hospital, and the other 4 are respective payment hospitals. But we've got this network of hospitals now that feel like they've got resources beyond just their standalone hospital, and that's made a huge difference. We have engaged all the constituents, whether it's the broader community, the board, the businesses, the civic clubs. We have engaged the medical staff at a much deeper level. We've engaged the employees, and in each case we do an employee survey and we ask them how things are going, and then we identify actions that can be taken to really create an environment for our employees. And so, so we have this balanced approach across the 5 strategic initiatives that we work on with each of the hospitals. And they start to feel a different culture is what really happens. And it's a culture of greater confidence. It's a culture of collaboration and trust that they can be successful, transparency, adaptability, and decisiveness. What we've found is that as we've come into most of these hospitals, previous leaders weren't willing to pull the trigger on difficult decisions. And so, so we've pulled the trigger on difficult decisions. We've embraced the community and the employees and the physicians, and so there's just a different culture that has been created with each of these hospitals. And in addition, we've looked at clinical niches that can be successful in new services, new programs. We've got, for instance, the Gerald Site program into the hospitals that we've implemented since we have come on board. One of the hospitals specializes in OBGYN services and draws them broader than their local area. We have the critical access hospital that really focuses on swing bed program, and that's been successful. We've partnered with Gesta Health and with Centerling Nephrology to create telenephrology with one of our programs to keep dialysis patients under one area. So we're always on the search for what's the next program that we can consider. And we've considered some that haven't worked. We've considered a detox program that we tried to attract patients from a broader region, and we didn't attract enough to sustain it, so we discontinued that. But we're always looking for kind of the next idea and the next innovation. And all that has led the hospitals to where they are now breaking even operationally, and where you know, before they were really struggling to make the next payment. But you know, it's still a work in progress. You know, we're still trying to make progress on some of these. One is improving reimbursement, which is just an ongoing challenge. Working the revenue cycle, all aspects of it. Renegotiating payer contracts. We've had success with some payers. We have not had success with other payers, and so that's still a work in progress. And so we're trying to create some kind of collaboration with insurance companies, which is very difficult. And so that's a piece that we're working on. And then we're also working with the state legislative body to look at some new mechanisms for funding rural health care. There's many states that have recognized that, yes, we need our rural part of the state, and our rural hospitals are struggling, and so we're going to create mechanisms to reimburse those facilities in a little different way. And in this state, we've got the haves and the have-nots. I mean, the health systems in Metro Atlanta are doing very, very well. And there could be some redistribution of how things are reimbursed in this state. So, so there are other places that the state could look at experiments that have been done in other states that have been successful, and we've pointed those out to the state legislators. One of our challenges is that even though we're at the point where we're breaking even operationally, we've got some legacy debt that's really hard to whittle away at. We've got long-term debt, and we've also got accounts payable that ranges from $2 million. One of our hospitals has $6 million in its account payable, and that's large for a small hospital. And so, you know, we're looking at ways to deal with that, to refinance in some way so that we can pay off some of that accounts payable on 50 cents on the dollar, and we're part of that accounts payable because we don't draw our fees when it's difficult. And so we're going to have to figure out how to address the legacy debt issue. We do have some of the healthcare systems that are around us that really don't have a collaborative mindset. They would just as soon see us go away. And they feel like probably the healthcare system would go on. The challenge is, because of the, you know, what I pointed out on the map, is that these communities, these counties, have become very dependent on these hospitals, not just for healthcare, because people can travel 30, 40 minutes for health care, and they do in many cases. But they are dependent on these local hospitals for the economics of the county. Businesses aren't going to be retained or attracted without strong health care and strong education. And we've just seen over and over again the effects on a community and a county when a hospital closes. So we don't want these hospitals to close. And we do need more of a collaborative mindset from some of the hospitals that surround us in communities like Statesboro, Dublin, Tifton, where there's a little more population. And we're just disappointed. You know, we've gone to all those hospitals and sought, you know, kind of a collaborative relationship, and in some cases, they may give lip service to collaboration, but their actions are more from a competitive mindset. So I think that's another reality that we're facing in the state. We do have just the ongoing challenge of overcoming kind of the local politics and provincial perspectives that happen trying to cross county lines even. We have just quietly created this shared services model that crosses county lines. But I think if we went to the county commissions in some instances and said, we're going to do this, they would be reluctant because of the local politics. And so I think that goes back to the map again. You know, these small counties that each have their high school team that competes with the next county, and so it's hard to collaborate across lines. But that will need to happen because the years are diminishing in terms of how we're going to be able to just stand alone as standalone hospitals, standalone counties without crossing lines and collaborating. We really appreciate Augusta Health and others that are trying to work with rural healthcare, and we need the partnership of tertiary centers to do that. We need both the tertiary centers and secondary centers to work with these primary hospitals in order to each of us play our role successfully. That's the way the patients are best served, is if each has its role. You keep patients closest to home. For those that need to be referred to a higher level, there's communication, there's clinical protocols to follow them, and the patients are served in the right place at the right time with the right professional services, and that's what needs to happen. And regional networks of care need to be created. And so there are developmental steps in that direction. And then all of us are dealing with the uncertainty of federal and state policy. Okay, there are still opportunities. I think there's opportunities in sharing services across hospitals. There's opportunities to partnership and affiliate with larger systems. There's opportunities to actually restructure and reorganize the ownership and the delivery model. So in some of these cases, it will take real kind of innovation, and it will take counties thinking in a very different way in order to restructure some of these organizations. New niche services, I think we just need to be continually looking at what we can do. You'll hear later from Robin about some of the things that she's done. Those hospitals that are thriving have been able to find particular niches that they do very well. The Rural Hospital Tax Credit Program, that's one thing the state has done. The state has done a few things. It's created the Rural Hospital Tax Credit Program that allows people to contribute to their local hospital and get the tax write-off. It's a no-brainer with the federal deduction, and we've worked at it. We've got one hospital that's over $700,000 in terms of that rural hospital tax credit. We've got others that are in the 100, 200,000 range, and that makes a difference. So when you look at the state overall, though, the $60 million that they made available, we're just a fraction of that. I think we're only $3 to $5 million in terms of what's been accessed there. So that's available, and we need to work with our businesses to realize that. They're going to pay the taxes anyway. They want it to go to the general fund, or do they want it to go to their local hospital? And so businesses can have an impact there. I think working with businesses to create kind of steerage of their employees toward your hospital is a way to do that, whether it's an insurance mechanism or discounts or whatever. The improved managed care contracts and relationships with employers, even though it's difficult, we're going to slog away at that in terms of improving the collaboration with the payers. And then Ken and others mentioned population health and the wellness and prevention screenings and care coordination and all that's involved with that, and eventually the payment for value. There's an opportunity in that for rural health care if we pursue that well. So there's hope. There's hope, even though the challenges are difficult and we're facing a stiff headwind. We've proven that things can work in these small hospitals, no matter how distressed they are. And we just need some of these things to kind of open up for us over time in order for us to be continually viable, so both rural Georgia and metro Georgia is successful in the long run. So with that, let me entertain any questions that you have. Yes?
Does your company consult, or does it manage, and are your contracts based on performance, or are there time limits on the contracts?
Yeah, we do managing primarily. We do some consulting. But we enter into a management agreement with a monthly fee, and then we have performance criteria associated with the contracts. And so
are the contracts long-term, or?
They're usually 3 to 5 years. We did one for a 1-year turnaround, and did the turnaround, and then they wanted to go back to local leadership in terms of continuing on. Management contracts have not had a lot of these rural hospitals have had negative experiences with management companies. And so there's kind of suspicion, and there's a misunderstanding of what management companies can provide. We're doing it from, there's somewhat of a business proposition, but primarily from an altruistic perspective and a humanitarian perspective in terms of really helping these communities. But that's our model, is a management contract, 3 to 5 years, monthly fee, and performance criteria associated with those.
Bill, can you be more specific about some of the shared services between the 5 hospitals? I know you talked a little bit about pharmacy and some others. But...
Yeah, and there's a whole array of them. The most common, the ones that we do the broadest, are around quality. So we share a quality person across many, the IT services across multiple hospitals, human resources, marketing, health information management, Paige, help me. Business office, revenue cycle. There's just a whole array of.
Are you the president over all 5 too?
So I'm the regional CEO. So I oversee all 5 hospitals, and then we have a local team at each hospital. Our ERH services include CEOs that have extensive experience, and we also have healthcare law experts, healthcare finance experts, people that have worked in nursing homes, and so we have kind of the partner level that I would call shared services across the 5, but then we have these other functional shared services.
Well, Bill, I think she was alluding to pharmacy. So as far as the 5 hospitals, are you centralizing pharmacy verification with one service? I mean, I know you can't cross state lines.
What we've done with pharmacy, with 2 of the hospitals, we share leadership across the 2 hospitals. And, but otherwise, the pharmacy is pretty locally driven. Our lab service, though, we share a lab leader across all 5. And then we have lead kind of supervisors at each of the hospitals. And so that person's salary is shared across the 5.
What about GPO kinds of things?
Yeah, we have, in terms of the group purchasing organization, we've gone with a group purchasing group, and we've been able to, when we've purchased new medical technologies, it's helped for us to have kind of the buying power of 5 as opposed to 1. And
so is that your own GPO?
No, we go with Paige again, speak to our GPO.
We actually have to. We were this side of the market as far as Irwin and Fitzgerald have done the agency with coffee and done that, and then the other side of the market does the HPG. But then we also use the agency approach with the aggregation model with all of the ERH hospitals and so forth that we can go out, and we have had some very good success, especially in the lab, on reducing those contracts.
Okay.
Pretty stiff.
Paige is our regional CFO for ERH, and also serves as the CEO for Irwin County Hospital and the CFO for Dormany Medical Center. And so we have people wearing multiple hats, which is something.
Bags.
Dr. Canto has one question.
Oh, okay.
Mel,
All right.
the 2 presenters before talked about the importance of boards.
Yes.
Now, when you go in, how do you interface with the boards of the respective hospitals in terms of their roles, and how do you keep them up to date with what you're doing? And is there anything special that you do with respect to board education when you when you come in and manage a hospital?
Okay. I mentioned earlier that each of these are health authority hospitals, and so they each have boards that are appointed by the county commission. And so we inherited these boards, but as we've been there over the years, we've helped them in the selection of new members and so forth, similar to the way Ken was mentioning. But we do incorporate board education into our board meetings. That's one of the best practices that we try to do, is to have a certain amount of each board meeting designated to board education. And then we work closely with the board in terms of other educational opportunities. Chris Park is the chair of our Irwin County Hospital, and he's here today. And so those kinds of opportunities we have them, attend various conferences, and then we have plans beginning in the coming years doing something similar to what Tim mentioned in terms of holding conferences for all our trustees and all of our medical leadership and so forth, and maybe holding them at tertiary centers as he suggested. And so we've been thinking about that and planning for that. So that's probably our next move in terms of board education. But we try to bring in kind of our governance best practices that we've learned over the 30 or 40 years that we've been in business there.
Thank you, sir.